Today, we explore Whipple's disease, a rare and fascinating infectious disorder that has puzzled doctors for over a century. We'll discuss its history, epidemiology, causes, organism, symptoms, diagnosis, treatment, and prevention. So let's begin our journey into the world of this mysterious disease. The disease was first described in 1907 by Dr. George Hoyt Whipple, an American pathologist. He documented a patient who suffered from chronic weight loss, arthritis, and malabsorption. Upon examination, Dr. Whipple observed fat-filled macrophages in the small intestine, marking the first known case. Interestingly, Dr. Whipple would later receive the Nobel Prize, but not for this disease, rather for his work on liver therapy in anemia. For decades, the exact cause of Whipple's disease remained a mystery, until 1991, when researchers identified the bacterium responsible, Trophorima whippleii. Whipple's disease is extremely rare, with an estimated incidence of less than 1 case per million people per year. It is seen more often in middle-aged white men, especially between the ages of 40 and 60. Most cases are reported from Europe and North America, but cases have been identified worldwide. It's believed that environmental exposure plays a role, as Trophorima whippleii DNA has been detected in sewage and soil samples. Despite the bacterium being found in the environment, very few people develop the disease, suggesting that genetic or immune system factors may make certain individuals more susceptible. The culprit behind Whipple's disease is Trophorima whippleii, a gram-positive actinomycete bacterium. It is slow-growing and difficult to culture, which made it challenging for scientists to study for many years. The organism primarily infects the small intestine, but it can also invade the heart, brain, joints, and eyes, leading to a wide range of symptoms. It hides inside macrophages, the body's immune cells, which prevents effective clearance and allows chronic infection. The exact mode of transmission of Trophorima whippleii remains unclear. However, evidence suggests oral ingestion of contaminated material may play a role. While the bacterium may exist harmlessly in many people, only a few develop the disease, indicating that immunodeficiency, particularly in macrophage function, genetic predisposition, chronic exposure to the bacterium, may contribute to the onset of Whipple's disease. Whipple's disease is known for its wide range of systemic symptoms because it affects multiple organs. The classic triad of symptoms includes weight loss, chronic diarrhea, arthralgia, or joint pain. Other common symptoms include abdominal pain and bloating, steatorrhea, fatty stools, fever and fatigue, lymph node enlargement, anemia. In severe cases, the infection can spread to the heart, causing endocarditis, brain and nervous system, leading to confusion, memory loss, or seizures, eyes, causing vision problems without treatment. The disease can be progressive and fatal. Diagnosing Whipple's disease requires a combination of clinical suspicion and laboratory confirmation. The main diagnostic methods include small intestinal biopsy, showing characteristic periodic acid Schiff (PAS), positive macrophages in the mucosa, polymerase chain reaction (PCR), to detect Trophorima whippleii DNA, immunohistochemistry, identifying bacterial antigens in tissue samples, electron microscopy, visualizing the bacteria inside macrophages. Because symptoms overlap with other diseases like celiac disease or Crohn's disease, accurate testing is essential. Whipple's disease is treatable, but requires long-term antibiotic therapy. The standard treatment plan includes initial phase, intravenous antibiotics, such as ceftriaxone or penicillin for 2 weeks. Follow-up phase, oral trimethoprim sulfamethoxazole, TMP-SMX, for at least 1 year. This long treatment ensures that the infection is fully eradicated and prevents relapse. In some cases, doxycycline with hydroxychloroquine is used as an alternative. With proper therapy, most patients experience significant improvement and can recover fully. Since the bacterium, Tropharima whipplei is widespread in the environment. Specific prevention methods are limited. However, general precautions include maintaining hygiene and avoiding exposure to contaminated soil or sewage, early diagnosis and treatment for those showing chronic malabsorption and arthritis symptoms, regular follow-up after treatment to detect any relapse. Early prognosis is excellent when treated properly, but relapses can occur if antibiotics are stopped too soon.